Welcome back to the deep dive. Today, we are stripping away the metaphor of the heart as just a single beating drum, and we're really looking at the mechanics of what is essentially a hydraulic crisis.
It really is. We're talking about a disease where the plumbing dictates the absolute fate of the pump.
And that disease is pulmonary arterial hypertension, or PAH.
Right. A crisis of resistance, pressure, and ultimately flow.
Now, usually when we talk about heart disease, we think about clogged arteries in the heart itself or systemic high blood pressure, the kind you get a pill for at your annual checkup.
Yeah, the garden variety hypertension.
Right. But this is different. This is a story about a very specific, almost isolated circuit in the body that just decides to break all the rules of its design.
It is the story of the other circulation, the one we frankly often ignore until it fails catastrophically.
So for this, we're anchoring our discussion in two major texts. Our primary source, the real deep dive, is Goodman and Gilman's chapter on the treatment of pulmonary arterial hypertension. That's where we'll get the molecular pharmacology.
The heavy lifting.
But we're also pulling in a companion chapter from Kat Sohn, the one on drugs used in asthma and COPD.
Which I know might sound like a bit of a strange pairing.
I was just about to ask, why pair a chapter on what is essentially a type of heart failure with a chapter on, inhalers?
Yeah.
It feels like we're crossing organ systems.
We are, but we aren't. And that's the key insight. Katsung provides the scaffolding. It teaches us the fundamentals of pulmonary pharmacology, how drugs are delivered to lung tissue, the basic signaling concepts like cyclic nucleotides.
Okay, so it sets the stage for the lung as a target.
Exactly. But then Goodman and Gilman takes those same concepts and applies them to a vascular disaster happening inside the lung's blood vessels. It's a perfect pairing of broad principles and specific pathology.
Okay, that makes sense. So before we get into the drugs, and we have some really heavy hitters today, from, drugs everyone's heard of to pumps you literally have to wear 24/7 to stay alive, we need to set that stage. We have to talk about this tale of two circulations.
This is fundamental. If you don't grasp the physics, the sheer mechanical difference between the left heart and the right heart, none of the drugs will make any sense.
So let's break it down. We have the systemic circulation
Right.
and the pulmonary circulation.
Systemic circulation is the one you're familiar with. It's the high-pressure loop. The left ventricle, that big muscular chamber, pumps oxygenated blood to your brain, your liver, your toes.
Everywhere.
Everywhere. It has to fight gravity. It has to squeeze blood through literally miles of branching vessels.
I always think of the systemic circulation as a fire hose system. The pipes are thick, they're pressurized, and the left ventricle is a weightlifter. It's a thick, muscular piston designed to just overcome massive resistance.
Precisely. It is built for pressure. Now contrast that with the pulmonary circulation. This loop only goes from the right heart to the lungs and back. It's a really short trip.
And the job requirements are totally different.
Completely. The lungs are delicate. I mean, think about what they are. They're these gossamer-thin sheets of tissue meant for gas exchange. Oxygen in, CO2 out. You can't blast a fire hose at a paper filter.
You'd tear it to shreds.
You destroy it. So the pulmonary circulation is, by design, a low-pressure, low-resistance system.
It's not a fire hose. It's a lazy river.
That's a perfect metaphor. Or a gentle irrigation system. The vessels are wide, floppy, and really compliant. They stretch easily. And because that resistance is so low, the pump, the right ventricle, or RV, it doesn't need to be a weightlifter.
Right. And if you look at an anatomical drawing, the right ventricle, it almost looks, pathetic compared to the left.
It's not pathetic, it's just specialized. It's this thin-walled, kind of crescent-shaped pouch that just wraps around the muscular left ventricle. It works like a bellows, not a piston.
A bellows. I like that. So it's for moving volume, not generating force.
Exactly. It's designed to move a massive volume of blood with very little effort. It is absolutely not designed to push against a wall.
And that, right there, is the design flaw at the very center of today's deep dive.
It is the central tension. In pulmonary arterial hypertension, that lazy river turns into a lead pipe. The blood vessels in the lungs stiffen, they thicken, and they constrict. The resistance just skyrockets.
So that bellows is suddenly being forced to act like a piston.
And it can't do it. The right ventricle tries. It tries to hypertrophy, bulk up like the left side does, but its geometry is all wrong. It eventually just dilates, stretches out, and fails. And when the right heart fails, you die.
It's a pure mechanical mismatch. The pump isn't built for the pipes it's connected to.
And the tragedy is the speed. I really want to dwell on the statistics from Goodman-Gilman for a second because they are just jarring. Before we had the targeted therapies we're about to discuss today back in the 1980s, what was the prognosis for this disease?
The text says the median survival was 2.8 years.
2.8 years. Just let that sink in. That is worse than many advanced cancers, worse than advanced breast cancer, worse than many lymphomas. This isn't your, I need to watch my salt intake kind of hypertension.
No.
This is a rapidly progressive death sentence if you don't treat it.
But with the drugs we have now, that number has changed.
It has. It's transformed. Survival has extended significantly. We're talking 7, 9, 10 years and beyond in some of the modern patient registries. We have converted what was an acute terminal illness into a chronic, manageable, albeit still very severe condition.
Okay, so before we unlock the medicine cabinet and talk about how we manage it, I want to clarify exactly what we are treating. We've thrown around the term PAH, but how do doctors actually know a patient has this specific disease and not just, I don't know, high pressure because their left heart is backed up and failing?
That is the single most critical distinction, and it requires a pretty invasive procedure called a right heart catheterization. You literally have to float a catheter through the veins, through the right side of the heart, and into the pulmonary artery to measure the pressures directly.
And you're looking for a specific set of numbers, right? A kind of diagnostic fingerprint.
Basically, yeah. 3 key numbers. First, the mean pulmonary arterial pressure has to be high. The classic definition from the text is greater than or equal to 25 millimeters of mercury.
Okay, so the pressure in the lung artery is high, but like I said, that could just be because the left heart is failing and it's causing a traffic jam, right?
Yeah.
Like a clog in the main drain causing the sink to overflow.
Correct. And that condition is called post-capillary pulmonary hypertension. It's a totally different disease. To diagnose true PAH, which is pre-capillary, you have to prove the left heart is normal.
And how do you do that from a catheter that's in the right side of the heart?
By measuring something called the pulmonary capillary wedge pressure.
I love this term. It sounds so mechanical. Explain wedge pressure to me like I'm, say, 12.
Okay. Imagine you're floating that catheter, which has a little balloon on its tip, down that lazy river of the pulmonary artery. The river branches into smaller and smaller streams, the arterioles. Eventually, you inflate the balloon and float it so far that it gets stuck. It wedges into a small branch.
So you've plugged the hole.
You've temporarily plugged the flow in that one tiny segment. Now, the pressure sensor at the very tip of the catheter is looking forward past the blockage towards the left side of the heart. Since there's no forward flow in that spot, the pressure it sees is really the back pressure coming from the left atrium.
Oh, I get it. So the wedge pressure is like a spyglass. You're using the right heart catheter to peek at the pressures in the left heart.
Exactly. It's a surrogate for left atrial pressure. In PAH, that wedge pressure must be normal, less than 15 millimeters of mercury. That proves the left heart is fine. The drain isn't clogged. The problem is in the pipes of the lung itself.
High pressure in the lung artery, normal back pressure from the heart. The blockage has to be in the middle.
And that blockage is driven by one thing: incredibly high pulmonary vascular resistance, or PVR. That is the enemy.
Let's talk about that enemy. What is physically happening to those lazy river blood vessels? Is it just a muscle spasm, like a Charlie horse in the lung?
It starts that way, but it becomes so much more. Goodman and Gilman outlines 4 distinct and pretty nasty mechanisms that drive that PVR up.
Let's walk through them one by one.
Okay, first is what you said, sustained vasoconstriction. The smooth muscle cells that wrap around the pulmonary arteries are just chronically tight. They're squeezing the hose 24/7.
Yeah, that's intuitive.
Second, and this is the really scary part, is vascular remodeling. It's not just a squeeze anymore. The actual architecture of the vessel changes. The walls get thicker, the smooth muscle cells multiply, that's hypertrophy and hyperplasia. The inner lining, the intima, gets thick and fibrotic and scarred.
So the wall gets thicker, which means the hole in the middle, the lumen gets smaller and smaller.
Correct. It's called concentric remodeling. And then third, you get in situ thrombosis. Because the flow is slow and turbulent and the vessel lining is damaged and inflamed, tiny little blood clots start to form right there in the small vessels. It's like sludge gumming up the works even more.
And the fourth mechanism.
Stiffening. The vessel loses its natural elasticity. All that scarring and remodeling means it becomes a rigid, brittle pipe instead of a compliant, stretchy balloon. It just can't expand to accommodate flow anymore.
Wow. Okay, so this leads us to the math moment of the episode. The text brings up Prezoy's law. And I remember seeing the formula in physics, but the implications are just wild.
It is probably the most important equation in all of hemodynamics. It states that resistance, which we can call R, is inversely proportional to the radius, R, raised to the fourth power.
To the fourth power, not just doubled, not squared.
To the power of 4. That means the relationship is exponential.
Yeah.
It's incredibly sensitive to tiny changes. If you cut the radius of a blood vessel in half, the resistance to flow doesn't double. It doesn't quadruple. It goes up by a factor of 16. 16. That's insane.
Goodman and Gilman puts it another way that I think is even more powerful. A mere 16% reduction in the radius of the vessel doubles the resistance.
A 16% shrink, that's barely anything. You couldn't see that with your naked eye, but it doubles the workload on that thin-walled right ventricle.
Exactly.
Yeah.
And that is why pharmacology is a game of millimeters, even microns. If our drugs can just dilate that vessel a tiny bit, if we can increase the radius by just 10 or 15%, we can drastically unload the heart. We are fighting for every single micron of lumen.
So how do we fight for it? The text lays this out really clearly. It describes an imbalance theory.
Yeah, you can think of the normal vascular tone in the lungs as a biological tug of war.
All right.
On one side of the rope, you have the vasodilators. These are molecules that are constantly telling the vessel, relax, open up, stop growing.
The good guys.
The main good guys here are nitric oxide, or NO, and prostacyclin, also called PGI2.
And on the other side of the rope, the vasoconstrictors. These are molecules that are screaming, squeeze, tighten, grow thicker, remodel. The main villain in this story is a peptide called endothelin-1, or ET1, and to a lesser extent, thromboxane A2.
In a healthy person, this tug of war is basically a stalemate.
It's a perfect balanced tension. But in PAH, the rope snaps. The body, for reasons we don't fully understand, stops making enough of the good guys, NO and prostacyclin, and at the same time it starts churning out massive amounts of the bad guy, endothelin.
So the good guys are AWOL and the bad guys are running the whole show.
Exactly. And with that insight, the entire pharmacological strategy for PAH just clicks into place. It's simple, really. 1, boost the nitric oxide pathway. 2, boost the prostacyclin pathway. And 3, block the endothelin pathway.
All right, let's start with highway number 1. The nitric oxide pathway. This is what the books call the CGMP axis.
Right. Let's trace the signal. In a healthy vessel, the inner lining, the endothelium, it produces this gas, nitric oxide.
Yeah.
NO is tiny, so it just diffuses across into the smooth muscle cell right next door.
And once it's inside the muscle cell,
It finds and turns on an enzyme called soluble guanylate cyclase, or SGC.
and SGC is basically a factory.
It is. It takes GTP and churns out a second messenger molecule called CGMP, cyclic guanosine monophosphate.
Okay, so NO is the signal, SGC is the receiver, and CGMP is the message. What does the message say?
The message, through a series of steps involving a protein called PKG, basically tells the cell, put the calcium away. It lowers the concentration of free intracellular calcium.
And calcium is the on switch for muscle contraction. So less calcium means
Relaxation. The muscle lets go, the vessel widens, resistance drops.
Now, Katzon makes a really interesting point here comparing this to asthma. In asthma, the go-to drug is albuterol.
Right, a beta agonist. Albuterol stimulates beta-2 receptors on airway smooth muscle to increase a different cyclic nucleotide, CMP, cyclic adenosine monophosphate.
So it's a parallel system.
Exactly. In the airways, CDMP is the dominant relaxation pathway, but in the pulmonary vasculature, CGMP is a huge player. It's a different currency,
Right.
CGMP versus CMP, but it buys the same result, muscle relaxation.
Okay, so if the core problem in PAH is that the patient is low on nitric oxide, the most obvious solution seems to be just give them more nitric oxide.
And we do. It's a therapy called inhaled nitric oxide, or INO.
But this isn't a drug you pick up at the pharmacy and take home.
Oh, no, not at all. Nitric oxide is a gas, and it has a massive limitation. It has a half-life of just a few seconds. Seconds. As soon as that NO gas crosses from the air sacs in the lung into the blood, it meets hemoglobin in the red blood cells. And hemoglobin absolutely loves to bind NO. It grabs it and neutralizes it almost instantly.
So it works in the lung where you breathe it in, but it never reaches the rest of the body.
Which is actually a huge benefit. It means it's a selective pulmonary vasodilator. It widens the vessels in the lung without dropping your systemic blood pressure in your arm or your brain. But because it gets eaten by hemoglobin so fast, you have to breathe it in continuously without stopping.
We're literally tethered to a gas tank.
Pretty much. That's why inhaled NO is almost exclusively reserved for the ICU. It's used for newborns with a condition called persistent pulmonary hypertension, or for a diagnostic test in adults that we'll talk about later. You can't send a patient home on it.
So we need a hack. We need a way to boost this NO signal without the gas tank. And this brings us to arguably the most famous drug in the world for a totally different reason.
The PDE5 inhibitors, sildenafil, which is Viagra, and tadalafil, which is Cialis.
I think most people have a general idea of what these drugs do for other parts of the body,
Yeah.
but why on earth do they work in the lungs?
It's the exact same mechanism. Remember CGMP, the little message molecule that causes relaxation?
In the message.
Well, the body has a cleanup crew. It's an enzyme called phosphodiesterase type 5, or PDE5, and its only job is to find and destroy CGMP. It's what terminates the signal.
It's the trash collector.
Perfect analogy. Sildenafil basically handcuffs the trash collector. It blocks the PDE5 enzyme. So whatever little CGMP the patient's body is still making, it doesn't get cleaned up. It sticks around longer. The signal accumulates.
So you're not making more of the message, you're just preventing it from being deleted. You're amplifying the signal.
Precisely. And it just so happens, by a wonderful quirk of biology, that the two places in the human body with the highest concentration of this specific PDE5 enzyme are the corpus cavernosum, the erectile tissue of the penis, and the smooth muscle of the pulmonary vasculature.
So it's a lucky biological coincidence that the same target exists in both places.
A very lucky and very profitable one. Sildenafil allows for sustained vasodilation in the lungs, which drops the resistance and unloads that struggling right heart. It's an oral pill, it works, and it improves exercise capacity.
But, and this is a massive but, there is a potentially lethal drug interaction here. The text has bolded all caps warnings about co-administering these drugs with nitrates.
Yes, this is non-negotiable. We're talking about drugs like nitroglycerin, isosorbide, mononitrate drugs used for angina, for chest pain.
Explain the physics of why this combination can kill someone. Don't just say it causes hypotension. What actually happens to the pump and the pipes?
Okay, let's visualize the heart and the circulatory system. The heart is a pump. But a pump is useless if it's not filled with fluid. We call that preload, the amount of blood returning to the heart.
Right, the volume in the tank.
Right. Nitrates are incredibly powerful venodilators. They open up the big floppy veins in your legs and your gut. This causes blood to pool in the periphery in your extremities. It dramatically reduces the amount of blood returning to the heart.
So the tank is already running a bit low.
Now add sildenafil to that. Nitrates work by generating nitric oxide, which creates CGMP. Sildenafil blocks the breakdown of that CGMP. You get a massive, uncontrolled, synergistic amplification of vasodilation. The veins just fall open completely.
So all the blood basically drains to your feet.
Essentially, the preload, the return to the heart, drops to almost zero. The heart is beating, but it's pumping dry. Your cardiac output collapses. Your blood pressure vanishes. And you can suffer a fatal cardiac arrest. It's a complete hydraulic failure.
That makes so much sense. It's not just low pressure, it's an empty pump.
It's an empty pump. Never, ever mix them.
Okay. Now, sildenafil works by protecting the CGMP that's already there. But what if the disease is so advanced that the endothelial cells are just dead? What if there's no nitric oxide being produced at all to even start the signal?
Then sildenafil is useless. You can't protect a message that was never sent in the first place.
So we need a different hack. This brings us to a newer class of drug, riociguat.
Riociguat is an SGC stimulator. I like to call this the remote start or the turbocharger for the system.
How is it different from Viagra?
It has a dual mechanism. First, it makes the SGC enzyme, the factory, hypersensitive to whatever tiny whispers of NO might still be floating around.
So it boosts the receiver's sensitivity.
Exactly. But second, and this is the absolute game changer, it can physically grab onto the SGC enzyme and turn it on all by itself, completely independent of nitric oxide.
Wow. So it bypasses the need for the endothelial signal entirely.
It does. It acts directly on the factory floor. Even if the endothelium is a wasteland, even if there is zero NO, riociguat can force the muscle to make CGMP and relax.
And riociguat has a special badge of honor, doesn't it? It's the only drug approved for a really specific, tricky subtype of pulmonary hypertension.
Yes, for CTEH, that stands for chronic thromboembolic pulmonary hypertension.
Let's unpack that acronym. That's a mouthful.
Normally, if you get a pulmonary embolism, a big blood clot in your lung, your body's own systems break it down over a few weeks or months, the pipe clears. But in a small percentage of people, for whatever reason, the clot doesn't dissolve.
It fossilizes.
That's a great word for it. It organizes into scar tissue. It becomes this permanent web-like obstruction inside the artery. The only cure is a very risky surgery to literally scrape it out.
So if a patient can't get the surgery,
then riociguat is the only drug we have that's been shown to improve flow and pressures in those patients. It's a really unique indication.
okay, that wraps up the nitric oxide highway. Let's move to highway number 2, the prostacyclin pathway.
The KMP axis.
The text calls prostacyclin PGI2 the most potent endogenous vasodilator. That's a big statement.
It is the heavy artillery. In a healthy body, endothelial cells make PGI2. It then binds to its own specific receptor on the muscle cell, the IP receptor.
And this activates a different enzyme.
Right. It activates adenyl cyclase, which turns out KMP.
Wait a minute, CMP, that's the same asthma messenger we talked about earlier with albuterol.
It is. It's another example of parallel tracks. In the lung vessels, both CGMP from the NO pathway and KMP from the prostacyclin pathway cause profound relaxation. But prostacyclin does something else that is critically important.
What's that?
It is a powerful antiplatelet agent. It prevents platelets from getting sticky and clumping together.
So it helps prevent those little microclots we talked about.
Exactly. And it also has anti-proliferative effects. It sends a signal to the smooth muscle cells that says, stop growing, stop dividing, stop thickening the wall. So it directly fights the remodeling process, not just the vasoconstriction.
So this pathway sounds like a perfect target. It hits tone, thrombosis, and remodeling.
It is.
Yeah.
But actually using it as a medicine is a logistical nightmare. Let's talk about the grandfather of all PAH therapies, epoprostenol.
This drug sounds intense just from reading about it.
Epoprostenol is synthetic prostacyclin. But chemically, it is remarkably fragile. It just falls apart in minutes.
So you can't swallow it in a pill.
Absolutely not. The stomach acid would destroy it instantly. Even if you inject it directly into the blood, its half-life is between 3 to 5 minutes.
So how do you possibly get it into the patient and keep it there?
You don't just give an injection. You need a continuous, uninterrupted intravenous infusion. This means the patient has to have surgery to place a permanent central line, a catheter that's tunneled under the skin of their chest and sits in a large vein near the heart. That line is then connected to a pump, about the size of a paperback book.
And they wear this
24 hours a day, 365 days a year.
I can't even imagine the lifestyle impact of that.
It's profound. I really want to paint a picture of what this looks like for a patient because it's not trivial. Every single day, they have to meticulously, sterilely mix the medication. For a long time, it had to be kept cold, so they had to keep ice packs on the pump itself.
Wow.
They have to shower with the pump in a special waterproof bag. They can't go swimming. And the anxiety...
The anxiety must be off the charts. Because of that half-life, if that tube kinks or the battery dies or the catheter gets infected.
The drug disappears from their bloodstream in 5 minutes, and because their body has become so dependent on this powerful vasodilator...
The vessels just slam shut.
Instantly. We call it rebound pulmonary hypertension. The pressure spikes to a level even higher than it was before they started the drug. The patient can go into acute right heart failure and die within a very, very short window. It is a true medical emergency. These patients live with the constant knowledge that their lifeline is a fragile little plastic tube.
But despite the horror of that lifestyle, people do it. Why?
Because it's a miracle drug. It's the only drug class in PAH that has been definitively shown to improve survival. Before epoprostenol, these patients died in 2 years. With it, they got their lives back. They could breathe, they could walk. For the sickest of the sick, the class 4 patients, it is still the gold standard. Nothing beats it for sheer potency.
But obviously the field has tried to improve the delivery to get away from that central line.
Of course, we developed treprostinil. It's a chemical analog that's much more stable. It has a half-life of about 4 hours.
4 hours is a much better safety buffer than 5 minutes.
A world of difference. And because it's stable, you can deliver it in different ways. You can still give it IV, but you can also give it subcutaneously like an insulin pump. A tiny needle under the skin of the belly, infusing continuously. No central line, no risk of life-threatening sepsis.
That sounds like the perfect solution.
Except for the pain. Subcutaneous treprostinil is famous for causing extreme, unbearable site pain. Patients describe it as a burning wasp sting that just never goes away. The drug itself causes local inflammation and vasodilation right under the skin. Some patients simply cannot tolerate the agony of the injection site, even if the drug is saving their heart.
It's a brutal trade-off. Pain versus life. What else is there?
Then we have Eloprost, which is an inhaled version. But unlike the continuous gas of nitric oxide, it comes in a little nebulizer. The problem: it has a very short duration of action.
How short are we talking?
You have to stop what you're doing and take a treatment 6 to 9 times a day.
That's basically every hour and a half you're awake.
It's incredibly disruptive. Your entire day is scheduled around your next nebulizer treatment. It's very difficult to hold a job or live a normal life.
Which brings us to the holy grail, an oral pill that can hit this powerful pathway, Selexipag.
Selexipag is a real triumph of medicinal chemistry. It is not a prostacyclin molecule. If you look at its structure, it looks totally different. But it's a small molecule that was specifically designed in a lab to fit perfectly into that IP receptor keyhole.
It's a master key, not a copy of the original.
Exactly. And because it's not a fragile lipid, it's stable. You can swallow it. It's a pill you take twice a day. No pump, no central line, no burning skin, no 9 times a day nebulizers.
But does it have the same punch as IV epoprostenol?
Generally, the consensus is not quite. It's a fantastic drug for earlier stage disease, for adding on to other oral therapies. But for that patient who is actively dying of right heart failure in the ICU, the IV pump is still king.
Now, there is a side effect mentioned for this entire class of drugs, oral, fofi, inhaled, all of them. That just sounds bizarre. Jaw pain.
Ah, yes. The infamous first bite pain.
Explain this to me. It sounds like a toothache or something.
It's actually a muscle cramp. The parotid glands, your big salivary glands back by your ears, are very, very sensitive to the vasodilating effects of prostacyclin. When you take the drug, those blood vessels dilate massively. The gland becomes engorged with blood and swollen.
Okay.
Then you go to take a bite of food, your brain sends a signal to the gland, squeeze out some saliva. The gland tries to contract, but it's swollen and engorged with blood. The result is an intense, sharp cramping pain right in the jaw.
So it's a Pavlovian punishment for trying to eat.
It is. Along with flushing, diarrhea, and headaches, it's actually a sign that the drug is working and you're at a good dose. But it can be absolutely miserable for patients.
Okay, so we boosted the two good guys, nitric oxide and prostacyclin. Now we have to turn and face the villain.
Endothelin 1, ET1.
This molecule is just bad news all around.
It is the most potent vasoconstrictor the human body makes, full stop. And in PAH, the levels of ET1 in the blood are directly correlated with how sick you are. The more ET1 you have, the worse your prognosis.
And it does two bad things, right? It squeezes and it builds.
Correct. It binds to its receptors on the smooth muscle called ETA and ETB receptors and causes intense, prolonged constriction. But it's also a powerful mitogen. That means it drives mitosis, or cell division. It's a growth factor that tells the vessel wall to thicken and scar and remodel.
So we need to block it. This brings us to the class of drugs called the endothelin receptor antagonists, or ERAs.
Right. We have 3 main agents in this class: bosentan, ambrisentan, and macitentan.
Let's start with the first one, bosentan. The text says it blocks both receptor subtypes, ETA and ETB.
It does. And historically, there was this huge debate in the field. Is it better to block both receptors, or is it better to be selective and just block the ETA receptor?
Why would that matter? Don't they both cause constriction?
Well, the ETA receptor, which is on the muscle cell, definitely causes constriction, but the ETB receptor is a bit more complicated. There's an ETB receptor on the endothelial cells, the lining cells, that actually helps clear endothelin from the blood. It acts like a little scavenger.
So if you block the scavenger receptor, ETB, wouldn't that make endothelin levels go up?
Theoretically, yes. And they do go up a bit. So the argument for a selective blocker was, let's just block the bad ETA receptor and leave the good clearing ETB receptor alone.
And what did the clinical trials show?
It turns out it probably doesn't matter that much. The overwhelming effect is constriction mediated by ETA on the muscle. Whether you block one or both, the drugs seem to work about the same clinically.
But bosentan, the first one, it has some serious baggage, specifically liver baggage.
Yes, it is known to be hepatotoxic. It can cause transaminitis, your liver enzymes shoot up, which is a sign of liver inflammation and damage. Patients on bosentan require mandatory monthly liver function tests. If the liver gets unhappy, you have to stop the drug.
And it's a drug interaction nightmare, right?
It is. It's a potent inducer of the CYP450 enzymes in the liver, specifically CYP3A4 and CYP2C9.
And inducer means it revs up the liver's garbage disposal system.
Right. It makes the liver chew up and eliminate other drugs much, much faster. And the most critical interaction here, the one you can never forget, is with hormonal contraceptives.
Birth control pills.
Bosentan eats birth control pills for breakfast. It makes the liver metabolize them so quickly that they become ineffective.
Which leads us directly to the most serious black box warning in this entire chapter: teratogenicity.
This is non-negotiable. This whole class of drugs, the ERAs, are powerful teratogens. They cause severe birth defects, particularly craniofacial abnormalities and heart defects. They are profoundly toxic to a developing fetus.
But let's just put this together. You have a drug that causes horrible birth defects, and it simultaneously disables the very pill that's meant to prevent pregnancy.
It is a recipe for absolute disaster, and that is why these drugs are under a special FDA program called REMS Risk Evaluation and Mitigation Strategy.
What does that actually involve for a patient?
A female patient of childbearing potential cannot just get a prescription and pick this up at Walgreens. She has to be enrolled in a specific program. The doctor has to be certified. She must be counseled and agree to use 2 different forms of reliable contraception, and the pill can't be one of them. And she must have a negative pregnancy test every single month before the specialty pharmacy is allowed to release the next month's refill.
It's a very strict lock and key system.
It has to be. The risk is simply too high to ignore.
Do the newer drugs in the class fix any of these problems?
Well, ambrisentan is selective for the ETA receptor and has much, much less liver toxicity, which is a big advantage. Macitentan is a newer dual blocker with better tissue penetration and also a safer liver profile than bosentan. But the pregnancy risk, that applies to the entire class. The monthly pregnancy testing is mandatory for all of them.
So we have our 3 big highways: boost NO, boost prostacyclin, block endothelin. But there is this small, lucky group of patients, a tiny minority, who get treated in a completely different way. The responders.
Ah, yes, the vasoreactivity test. This is a crucial step at the time of diagnosis.
You mentioned this earlier. When you first diagnose someone, you take them to the cath lab, you have that catheter in their pulmonary artery, and you're measuring the pressure.
Yeah.
Then what?
Then you hit them with a powerful, short-acting vasodilator challenge. You have them breathe in nitric oxide, or you give them an IV infusion of adenosine or ibuprostanol.
You basically blast the vessels with a vasodilator and see what happens.
And you watch the pressure monitor. In about 90% of patients with what we call idiopathic PAH, almost nothing happens. The pressure might dip a tiny bit, but not much. The pipes are too stiff, they're too remodeled and scarred shut.
But in that lucky 5 to 10%.
The pressure drops like a stone. Specifically, the definition is that the mean pulmonary artery pressure has to drop by at least 10 millimeters of mercury, and it has to result in a final pressure below 40. The vessels just melt open, they relax dramatically.
These are the responders.
These are the responders. And what this tells us is that their disease, at this point, isn't driven by fixed scarring and remodeling. It's almost entirely driven by that first mechanism we talked about.
Yeah.
Pure, intense muscle spasm.
And because it's just a reversible spasm, you don't need the fancy, expensive drugs.
You can use simple, old, cheap drugs, calcium channel blockers or CCBs, high-dose nifedipine, diltiazem, amlodipine, the same generic pills your grandma might take for her systemic hypertension.
This sounds amazing. Why don't we just try everyone on CCBs first? It would save thousands of dollars and a ton of side effects.
Because for the non-responders, for that 90%, giving them high-dose CCDs can be fatal.
Why? What's the mechanism of harm?
Calcium channel blockers are systemic vasodilators. They lower blood pressure in your whole body. If a patient has rigid, scarred-up lung pipes, the CCB won't open them. They can't respond. But the CCB will still drop the systemic blood pressure in their arm and in their aorta.
So the resistance in the lungs stays dangerously high, but the pressure pushing blood to the right heart suddenly drops.
You've got it. You lose the perfusion pressure to the right ventricle itself. The RV, which is already struggling against this massive wall of resistance, suddenly gets less of its own blood supply. It becomes ischemic. It collapses. You can precipitate acute right heart failure and death.
So the absolute rule is no test, no CCBs.
Never, ever, ever empirically treat PAH with calcium channel blockers. It is malpractice. You must prove vasoreactivity in the cath lab first.
Let's zoom out a bit and look at the overall strategy. We have all these tools now. How do clinicians decide which ones to use and when?
We classify patients by their functional class. This is the WHO classification, which is very similar to the New York Heart Association scale for left heart failure. It's all about symptoms.
Okay, walk us up the ladder.
Class I is asymptomatic. You have the disease hemodynamically, but you feel fine. You can run a marathon. We almost never find these people unless we happen to be screening family members of a known patient.
Class 2 is mild symptoms. You're fine at rest, but if you climb a few flights of stairs or carry heavy groceries, you get winded.
Class 3 is marked limitation. You're getting short of breath with everyday activities, like walking to the mailbox or taking a shower. Your life is becoming significantly restricted.
In Class 4.
Class 4 is symptoms at rest. You are sitting in a chair, doing nothing, and you feel like you're suffocating. The right heart is failing.
So how does treatment map onto that ladder?
For most class 2 and 3 patients, the current standard of care is to start with upfront oral combination therapy. You hit them with 2 drugs from different pathways right away.
So like an ERA plus a PDE5 inhibitor.
Exactly.
Yeah.
A drug like ambrisentan plus a drug like tadalafil. The AMBITION trial, which is mentioned in the text, proved that starting with 2 drugs from the beginning is better than starting with 1 and adding another one later.
Why is that?
You're being more aggressive up front. You're trying to prevent that irreversible vascular remodeling before it gets too entrenched.
But what about for class 4? The sickest patients.
If you present in class 4 or if you're on oral drugs and you're still deteriorating, you need the pump. That's an indication for parenteral prostacyclins, usually IV epoprostenol. We need to turn things around immediately, often as a bridge to a lung transplant.
Before we close out, we have to talk about the supportive care. The text mentions these, and they feel like the unsung heroes of treatment.
They absolutely are. They don't target the pulmonary arteries directly, but they are critical.
Let's start with diuretics. Why does a patient need a water pill, like Lasix, if this is a lung vessel problem?
Because of a fascinating mechanical principle called ventricular interdependence.
That sounds fancy.
It's actually simple mechanics. The right ventricle and the left ventricle aren't 2 separate rooms. They share a wall. That wall is the interventricular septum.
Right.
When the right ventricle is failing under all that pressure, it gets big, dilated, and overloaded with fluid. It bulges into the space of the left ventricle.
It literally squashes the left heart.
Exactly. It flattens the LV. This prevents the left heart from filling properly with blood during diastole. So by using diuretics, we remove excess fluid, we reduce the volume load on the RV gets smaller, and the septum moves back to the middle.
Yeah.
This allows the left heart to fill again, and that actually improves the body's overall cardiac output.
That is fascinating. It's not just about getting rid of water weight. It's about using geometry to make room for the other pump to work.
Precisely. Then we have anticoagulation.
Warfarin, usually.
Yes. Because of that sluggish flow and the tendency for those in situ microthrombi to form, we often anticoagulate these patients to try and keep the pipes as clear as possible.
And finally, oxygen.
This is a big one. Hypoxia low oxygen levels is a potent pulmonary vasoconstrictor. It's a natural reflex. If your oxygen levels drop, the arteries in your lungs clamp down, we absolutely have to prevent that additional insult. So we tell patients to wear their oxygen and keep their saturation above 90%.
So we have this massive arsenal now. We've dilated the vessels, we've blocked the constriction, we've unloaded the heart. But is it a cure?
No, it is absolutely not a cure. It is management. It's buying time and improving quality of life. The underlying proliferative disease is still there.
And that leads perfectly to the final provocative thought. Where is the future of this field headed?
The future is moving beyond just vasodilation. We are trying to stop the proliferation. We are trying to treat this more like a cancer of the blood vessels.
And the text gives a hint of this with the imatinib story.
This is such a cautionary but also incredibly inspiring tale. Imatinib, brand name Gleevec, is a cancer drug. It's a tyrosine kinase inhibitor. Its job is to stop certain types of cells from dividing.
And they tried it in a clinical trial for PAH, the IMPRIUS trial.
They did. And on a physiological level, it was astounding. It seemed to actually reverse some of the vascular remodeling. The pulmonary vascular resistance dropped significantly. It was one of the first drugs to really seem to target the root cause, the cell growth itself.
But there's always a but.
There's a big but. The side effects were unacceptable, specifically a high rate of subdural hematomas, which is bleeding on the surface of the brain.
Yikes. That's a deal breaker.
Total deal breaker. It turns out shutting down those fundamental growth signaling pathways systemically has consequences for the integrity of other blood vessels, like the ones in the brain. So imatinib is not used for PAH, but it proved a concept.
That we can potentially reverse the remodeling if we can find the right target with an acceptable safety profile.
Exactly. The next generation of drugs that are in trials now, like sotatercept, which works to rebalance a growth signaling pathway called the BMPR2 pathway, they're looking at the genetic reprogramming of the vessel wall. We're slowly moving from just opening the pipe to rebuilding the pipe.
That is a very hopeful note to end on. From a death sentence of 2.8 years to a manageable chronic disease and maybe, just maybe eventually, a curable remodeling defect.
That is the ultimate goal.
If you really want to see the intricate, beautiful diagrams of these signaling pathways we've been talking about, you had to go to Goodman and Gilman, the chapter on treatment of pulmonary arterial hypertension.
And for the broader context of how drugs work in the lung, check out Katzung's chapter on asthma and COPD. As always, reading the source material is essential to really lock this in.
Thanks for listening to this deep dive. We'll see you next time.
Stay curious.